Ellen Richards. I'm with Integral Care. And under challenges, we talked about the issues of co-occurring chronic health and mental health conditions and the challenges for people to tackle both of those areas to seek wellness. There's issues around navigation and people being able to connect to the services that they need across the community and needing to increase connections to a wider range of services. There's challenges around funding, and this had to do with the coverage that people have. For example, certain types of coverage gain better access to services, particularly when you get into the areas of specialty care and things like that. So it would be nice that regardless of what type of coverage you have the same level of access. There's a big issue of stigma in accessing mental health services. We've discussed specifically the African American communities and the Hispanic communities and difficulty accessing mental health services and helping people understand that it's okay to seek help. With the way that our community is shifting and moving to the unincorporated areas and to the further outlying areas as the costs of housing rise, it increases access issues for people getting into the inner city and accessing the care that they need. And we've talked about transportation and the challenges around lack of public transportation for those people in those unincorporated areas. In terms of, I'll move to systemic change, picking up on transportation. Just concerns about our priorities in terms of where we're putting our emphasis in improvements. So improvements to places like, to arterials like MOPAC, or building rail in areas that are higher income and not thinking about access for lower income populations and how those are the populations that are having trouble accessing services. We've talked about the need for more after-hours mental health care, particularly for families who are involved in, for example, the juvenile justice system. They're working 2 or 3 jobs and they can't come during the regular working hours, so we need to make sure there's access during those other hours. And sorry, I'm sort of flipping my papers around here. Again, kids in the juvenile justice system, and this is true with a number of areas, but we need to improve communication and collaboration among agencies that are serving the same individual so that anybody that's touching that individual is able to work collaboratively and improve health outcomes.
Hi, I'm Shauna Crosby with the Austin Child Guidance Center, and several of the issues that you brought up initially were also covered by our group as well. So I'll just add some additional ones. A lack of funding for prevention services is a huge one. I think services in general is concerning, but specifically about prevention services. And one of our members of our table also brought up the issue of we're really just not sure how to measure improvement in mental health or how to measure prevention within mental health. So we all need to come together to identify indicators of improvement. Mention the continued stigma within mental health, particularly of people of color and within the veterans population. We also discussed issues around mental health literacy, needing to educate physicians and nurses and school personnel about mental health issues. And we also talked about the limitations of, or difficulties, I should say, in finding Spanish-speaking clinicians in Austin. It's very difficult. Also, physical issues, medical issues are often treated differently than mental health issues. And even within the mental health profession, substance abuse issues are treated differently than they are mental health issues. And kids are often treated separately from parents. The other issue is that many of our systems of care are not trauma informed. And so we know from the Adverse Childhood Experience study that David brought up earlier that childhood trauma impacts not only mental health but physical health. So if we're able to identify kids who've experienced trauma early on and help them, we will be in a better place. And so when I say trauma informed, I mean that those are systems of care that not only just provide trauma treatment, but the entire system of care is trauma informed. It means that we're screening every person for their own history of trauma. and that we're reducing the opportunity for them to be re-traumatized within our systems of care. So within juvenile court, that might be, reduction in restraints. We also need a more holistic approach, and I think that's it.
Hello, my name is Angela Vickery, and I'm with Austin Recovery. Just again, the challenges, a lot of them have already been mentioned here. I do want to talk about the fact that for substance use specifically, there's no funding available in the 1115 waiver. We didn't opt in for Medicaid expansion, and so that's still an unfunded need in the community. I also wanted to point out that we see the marketing strategies that promote use and target very vulnerable populations, especially at the city level, with Austin being a party city and kind of having that culture. I think that's a true challenge that we have. In talking about systemic infrastructure, I'd like to mention that we need to build a system that addresses basic needs, especially poverty, education, housing, and equality. I think there needs to be a community health or public health advisory committee that explores what the needs are in the community, as well as, is this a true need? What are the solutions to address this? And we really need to launch a true recovery-oriented system of care. The addiction community has that. It's really fairly new to the community. However, I'm talking about system-wide that addresses medical, mental health, transportation, basic needs like housing, jobs, and a lot of that really boils down to the fragmented services that we provide and the siloed funding that's available for that. In other words, a client or a potential individual may access care in one setting, but once they get through that, there's a wait list, or there's a different set of criteria to access service in another place. So we need to come together and streamline that and be able to provide a true recovery-oriented system of care.
Julie Macher, I'm with the City of Austin Health and Human Services Department. And we talked about the challenges with a cultural change, financial burden, kind of both ways, whether, the cost of using tobacco products and then the cost of quit resources, education, socioeconomic factors, lack of motivation and fear of failing. We also talked about, from an organizational standpoint, being able to provide support services, having a systemic outreach, following best practices and enforcement, the impact on the camaraderie and strategic rollout. And then some of the changes that we talked about were ordinances that would happen on a city level or higher, better connection of the resources and support that's available and being able to navigate through that and meet population needs and make sure that it's current and updated. Organizational cultural change, put more of an emphasis on health, rewarding successes and a supportive environment, and being able to refer out more than just through the electronic medical record, but through different social services.
I'm Jen Curtis, I'm with Cardia, and we were discussing HIV and STDs. And I will speak to the challenges because it kind of comes full circle to the systemic changes needed. As far as HIV and STDs, our table had a lot of youth experience, so we were focused there mostly. But we were looking at just the stigma that still exists surrounding services and getting tested for HIV and STDs, but also just the misunderstanding and the miscommunication that happens regarding the education for our youth around HIV and STDs, and that the misunderstanding and the misinformation among the people who are making policy regarding health education for our youth. And so the health policies that can be created or that are made surrounding this issue are sometimes themselves stigmatizing and themselves also decrease the accessibility to the education that is needed. Just one huge example, taking away health education classes or no longer having mandatory health education classes in the school system takes away a prime opportunity to reach a target population surrounding this health issue. And so the challenge, or I guess a systemic change that could be made, is just education for our policy makers so that they are creating policy that speaks to all the populations that are affected by this and creating more accessibility to get the information that they need.
Very good.
My name is Todd Jermstead. I'm going to be talking about veterans issues and homeless issues. I have to say this was very, very interesting. I learned a lot on this. And basically we're looking at homeless, and then veterans break down into two categories. One would be those with VA benefits, which is good. But then we got a number of veterans that got discharged without benefits, and they're going to have to come back with the local level also, and those are going to be problems. But one thing I learned that kind of surprised me is that for homeless and even for veterans that are not getting benefits, probably the number one concern is the lack of dental care. And that I now started noticing, I see a lot of toothless homeless people. And you can imagine how that's going to impact nutrition and everything else. So we really need to do a lot more as far as providing dental care. And then as far as systematic changes, we basically identified 5. One is just breaking perceptions. And what's happened is that we think of homeless primarily as males. We don't think of females and young children and families. And that's also true with veterans. We still think of veterans in the military as a male-dominated force. That's no longer true. But we're shaping policies and programs in that to address a male population and overlooking both our female veterans, which are making up a huge amount of the military forces and leaving the military, and the males. And then the other thing is looking at shelters, which actually kind of feeds into the first perception, is that there's shelters for men, but there's not enough shelters for single females or females. There's not shelters for females with children. You also have all kinds of issues. If it's a family unit, a man, husband, wife, and children, the man has to go to a male shelter. Wife may take the children. You break up the family unit. Even if it's just a single female with a male child and a female child, they may have to separate that family, at least at a certain age. So we need to be thinking about shelters in a much broader way than what we're currently doing. The other thing is just is looking about expanding like Capital Metro to accommodate these people that are homeless, and there's right now kind of a fairly narrow definition for getting a financial break on Capital Metro. We really need to kind of expand that because that's going to impede accessing services if they can't do it. The number one priority was looking at MAP and those co-payments. Apparently what I was told is that if you have a shelter, you have to pay a co-payment regardless of what your income level is. So if you're on the streets, you may be able to get more medication. If you're in the house, then you have to decide, should I either go back on the streets or give up food? And it may sound like a small amount, but if you've got like 10 medications at a time, for a poor person, $5 is a lot of money. So there really needs to be an income basis for accessing this. And then the last recommendation is just developing some sort of centralized function as far as providing services and referrals, so you don't have to go from this place to this place to this place, but a one-stop shop where you can be told how to fill out these forms, how to access the services.
Hi everyone, my name is Paige Drinking. I'm the director of the Ventanilla de Salud at the Mexican Consulate. We are the Immigration, Refugee, and English Language Learners table. We're small but mighty, and we actually get our own whole forum next month, so hopefully all of y'all will come back for the Diversity and Language Access Forum. A lot of the things that really our population encounters is going to be touched on by everybody else's tables. There's a lot of intersections as far as chronic illnesses and health issues, specific health issues. So we were talking a lot more about access to care and why our population a lot of times doesn't end up inside the health system or has issues accessing the health system, paying for health care. So we talked a lot about barriers. A huge one is language access, of course, which is why we're having a whole forum on it next month. And moving beyond just Spanish language, which the resources there still aren't adequate, right? But when you're talking about different Asian languages, African languages, they're not there at all, right? Or they're just really, really insufficient. So that's a huge barrier. Looking at refugee populations, they get set up with medical care when they first get here, but oftentimes that medical care runs out. At 8 months they end their Medicaid coverage, and they aren't aware that it's ending. They don't know how to renew it. There's a lot of misconceptions about how the U.S. healthcare system works, how they can access it, and so trying to bolster the case management services for that refugee population and make sure that they're getting the follow-up that they need in order to really transition into the medical system here in the U.S. is really important. We also see a lot with immigrant communities, especially undocumented communities. There's a lot of mistrust of large systems because of their tenuous immigration status. They're not sure whether they're going to get reported, whether they'll get deported, all of those things. There's a lot of misconceptions about what they can access, what they qualify for and don't qualify for. And then there's a lot of stigma within certain cultures, different Asian cultures, Latino cultures, about talking to strangers about your personal information, your medical information. So when somebody approaches them and says, for example, what are your sexual behaviors, right? They're going to be very turned off by that and not want to continue accessing care. So those were some of the barriers and some of the things that we talked about as structural improvements. We echoed the idea of a one-stop shop. We really hate having to send our clients on wild goose chases, like, oh, maybe you qualify here, but if you don't, go here. If you don't, go here. A lot of times my clients will just stop after the first one because they're kind of tired of it and they don't have time, they don't have energy to go to 3 or 4 different places to register for things or enroll. We also talked about really improving community engagement and outreach strategies to try to make them really culturally proficient, potentially using more promotora services, more community health workers that understand the communities that they're trying to reach and can meet them on that level and communicate with them in a culturally appropriate way to try to get them into the door so that they feel comfortable accessing the medical system. And we also talked about not just talking about culturally relevant outreach strategies, but hopefully getting funders together and making that a real requirement for the funding of programs, deciding what that looks like, what is culturally relevant and appropriate and linguistically relevant and appropriate, and making that a requirement to receive funding.
Good morning. My name is Tanya Lavelle. I'm the Senior Manager of Advocacy at Easter Seals Central Texas, and I represent the People with Disabilities table this morning. A lot of what we discussed has already been talked about from some of the other presenters, so I'm going to try and manage redundancy. So one of the things we talked about that I don't think others have focused on too terribly much in terms of outcomes, which was the first question, is that we feel that unfortunately a lot of the times outcomes are a second thought after people are developing programs, after people have implemented programs. And coming from a policy background, that's a really difficult thing to do because a lot of the times when you're trying to get more money, when you're trying to really implement these programs, lawmakers and funders are not really interested in doing that if you haven't shown that you are able to achieve outcomes other than numbers. And some of the outcomes that we talked about really they revolve around quality of life and really tracking people to make sure that what you're doing is helping them in the long term, and especially people with disabilities. This is a lifelong journey. And so we really would want to see more of a focus on outcomes coming before and during the program planning process. And in terms of other systemic changes, it was kind of echoed throughout the mental health and substance abuse folks, as well as the chronically homeless. But we do want to see a place where people can go to one place and figure out what they need to do. And for people with disabilities, the first time that they often run into the healthcare system is through their pediatrician or through their primary care provider. And in some of the systems, in some of the hospitals, there are social workers on staff, and there are child life assessors on staff, and those are people that are fantastic to help families really realize where they need to go for all the different services, because it has been mentioned by other people that it can be very confusing. And with people with disabilities, we have families of single mothers, families with multiple children, and it can really be hard for people to navigate all the different services available to them. So we really would like to see a bolstering of that part of the provider pool, as well as education across the spectrum for parents, for providers, and really for the other agencies that touch these families to try and help them get access to the services they're going to need really for the duration of their lives, dealing with their children, really kind of learning what they themselves need to be successful parents and to be successful family members and caregivers. So that's what we focus on.
Wow.
Hi, I'm Maren Strachan. I'm from Austin Children's Services. We talked a lot about the system changes that we thought were needed. All had to do with how to get funders and organizations on the same page about key performance indicators and impact indicators. And if we can agree on the impact indicators, maybe funders will be more likely to fund preventative programs if we can show that we're actually doing work. So the systematic change that we thought would be great is you already have indicators that are written out right here with CAN. Some of the work has already been done about an agreement of what we should measure, how we should measure impact. And if we start putting together metrics around these indicators, we can bring funders to the table who will be more likely to fund the programs and the services that we can demonstrate make change.
Hi, I'm Ellie Haggerty with St. David's Foundation, and I'm representing the Dental, Vision, and Hearing Table. And we were all dental-related foundation staff, actually. And some of the systemic changes that we discussed had come up several times today on the need for adult coverage for dental services and policy changes related to coverage. We also felt like there was a large need for culturally competent education and marketing to increase awareness around the need for preventive services as well as the existing resources in our community. And as many tables have discussed, we wanted to echo the need for coordinated efforts related to measurement as well as the delivery of services and communication of that coordination and measurement of progress. Lastly, we thought that there were policy changes related to the level of providers who can perform different services specific to dental care.
Good morning. My name is Robert Gibson. I'm with the City of Austin Health Department of Health and Human Services, and I'm representing the table on teen pregnancy, family planning, and child and maternal health. Some of the barriers or challenges that we discussed in addressing key health issues and achieving the best outcomes for this population is these are the following: prevention, gender bias, continuum of care, cultural barriers, economics, and obviously its impact on education and a number of other things. Competitiveness, sometimes for grants, there's a lot of opportunity for funding to be received here, but are we coordinating together to work on these projects? Early intervention that was discussed earlier, dating abuse and just the idea of healthy relationships and what that looks like, and also health literacy, meaning language, stigmatism around different services and cultural issues, and also just not just basic reading and writing skills, but also class standards, as was discussed over here. And so we saw a common elements to all of these different barriers where the areas in which we see affecting these areas are schools, policies, particularly obviously on the state level and the federal level, and also lack of collaboration amongst providers to address these issues. So based on that, some of the things that we came up with to address these barriers was a need for information about funding and more transparency, more collaborations between healthcare providers and nonprofits. So when there's these opportunities that come up, let's work together in submitting a grant application, or if someone gets funds, let's work together to partner up and address these issues. Also, the need for more community conversations, increasing community participatory action research, interacting with the community, having the people in the community be a part of the intervention, and discussing how they would what needs they would like to see met, and particularly youth, using those youth as peer health educators, allowing them to be those that get empowered and transfer that information to their other peers, because a lot of times adults, we give the information, but the most effective thing is to hear from someone that looks like you and is your same age. Lastly, we also talked about allowing healthy relationships to be incorporated into education. So many times we understand that there's a fight for school time and being able to get those core curriculum skills, but we realize that's also a needed area of education and incorporating that into the health education curriculum. And then lastly is just outreach, not just marketing and advertising, but actually going into those uncomfortable areas, those areas where youth are, that they're populating, whether it's recreation centers or outside of school time, to actually get this information to them. Thank you.
My name is Linda Terry. I work for the Chronic Disease Control and Prevention and Control Program with Austin Travis County Health and Human Services. We also were a small group, but we actually came up with many of the same things that were talked about not only by other groups, but by panelists. So to just skip over the challenges, we have, of course, resource availability, engagement, cultural awareness and sensitivity, the way of educating the patient or the client. And the last thing was just briefly touched on, and that is the development and networking of community partnerships. Use the expertise that's already available in the community. Don't hesitate to call those people who may already have some kind of program going, or that you could combine with them to receive additional funding and share those responsibilities. In the area of systemic changes, there is already some change in the medical model about the way that physicians are provided an incentive to earn money, and we're talking more of a pay for performance, not the treadmill of patient care where it was based on the number of patients you could see in an hour, but rather on those kinds of issues like they can only come twice a year for a blood pressure check, or they have quit smoking maybe after a long time. But to value the patient care and the cost of patient care by performance. The other was the access to care. We've talked about all kinds of things like that, but not only the decentralization of medical services or going to where the client is to provide the service, but that would also include bus line availability, appointment availability. We know in MAP historically you have to wait for a long time to see a physician, particularly those who are of low SES. And then online availability. You know, many of us have access to our medical reports. You set an appointment online. We need to increase that so that more people in the community can have access to do that. And last, we decided we needed more patient-centered care and control. And much of this is occurring already with the changes that are being made in EMRs that you may be seeing in your own clinical setting, where you go to the physician where they ask you about how much you drink, whether you smoke. In the event, they can't move on in that process until they answer more questions if that comes up. So sharing that information is also going to be a valuable systemic change.
I am Denise Esper. I'm currently with Lone Star Circle of Care, and our table is navigation, which I think even in the introductions, I thought it was really interesting. We had someone come over and say, navigation, okay, what is that? And before he joined our table, and I think that's part of the problem, and one of the ones that we identified is that the need for a common language in and of itself is part of the fragmentation. But as far as the challenges, we identified fragmentation, but I think it's also worth mentioning before I go over some of the systemic changes. ED visits was also brought up, and this was prior to hearing the panel discussion, but we were talking about that ED visits, while it's identified as a challenge because of that specific need is met, and then they can leave and come back when they have the next specific need. While I'm sure it's great care and everything is being provided at that time, it's almost rewarding that behavior and not focusing on the preventative opportunity that we may have. The challenge still therein lies, I mean, there's an opportunity, but the challenge is it is an emergency room, it is illness focused, and so it would kind of be reinventing what all is done in the emergency room, but if we could identify and address some of the things that we were talking about at the table from a navigation perspective, if those can be addressed when you have that captive audience, that would go a long ways and allow us to work within the system that we currently have. Some other items, again, fragmentation being one of the primary challenges that we addressed. So connectivity and collaboration on the front line, which is what navigation is viewed to be. Navigation can solve some of that fragmentation, at least locally. But there was a lot of focus on, we rely on navigation of people contacting us. And one of the things that were brought up at the table is people don't often reach out or know to reach out for assistance other than just going to the emergency room. So there was a big push at our table about focusing how we might do outreach out into the communities, and some things we've already heard about into the churches, into the schools, into the neighborhoods, the grocery store, looking at different communities and whatever forms of communication work in that particular community. Connectivity and collaboration, again going back to that need for common language. Access to shared centralized data. One of the gentlemen at our table that's no longer here, he is with Home of Hope World, He, when Dr. Hernandez was talking about the Community Care Collaborative, it was the first time he had ever heard of that. Other people I've heard didn't even know about the Community Care Collaborative and the vision and mission that lies there. And so the idea that not everyone's aware, again, it's that common language, and that's a fragmented system even within our organizations, not just organization to patients or community members, but fragmentation amongst the organizations. So I wrote a book. And on this book, it identifies like organization to organization, organization to community, community to organization, I mean, going through all those different scenarios. And then the frontline navigation to access all is described in the CCC, utilizing, integrating, and participating with that collaborative. If there was a system by which you could utilize all as described in the vision and mission with, again, the focus on the push and the pull, inbound and outbound, with trained and empowered frontline staff. We had people here that were educators or focusing on community health workers that weren't aware of the work that's being done amongst the CCC. So again, huge opportunity there. And to Larry Wallace's comment about the physician shortage, also the idea it's not just a place, an answering service, or someone to point you in the next direction. There's an opportunity for virtual care to be delivered in the form of a navigation.
Nelda Garcia, nurse with the City of Austin with immunizations. We too were a very small table. Unless it's an endemic or an epidemic, then we're your BFFs. So you want to run to us. What we're going to focus on, everybody's been focused on lack of collaboration, and I think when Dr. Mark Hernandez stated it's not the service you provide, it's a service you provide, not the badge you wear. I think that's huge, because so many times working in the hospital-based system where my background is mostly in, if this certain hospital is there, this one can't be there. It's ridiculous, and it's affecting our patients. Also, another way is somebody else has already focused on a lot of things that we've said, is outreach, not just waiting for them to come to us, but for us to go to them. I know with the City of Austin, we go to ARCH, we go to day labor. We're all over the city and always working with ATCIC. We're collaboration with them. So we all try to find each other out to help the community, because they're not going to come to us. We work with high-risk populations. She works with children, and those children have parents that are also needing vaccines. So we have to start at the beginning so it doesn't start into something that doesn't need to happen. We also have advocated for a database, and right now we do have the MTRAC, which is the state registry. So anybody who comes and gets vaccination within the city or any place within the city of Austin or in the Travis County or the state of Texas, it'll go into this huge database. And if you move from Lubbock to McAllen, El Paso to Vernon or whatever's east, they're going to be in the system, and you won't be revaccinated for vaccines that you don't need. Although it doesn't harm you to get revaccinated, you still, I had to throw that in there.
Nice plug.
Can't take us out of there.
No.
You will need, it's nice to have that database, because a lot of us don't keep our vaccine records. We have to, come on, let's be rational. We don't keep certain things. But it's nice to have that database that we can't do without consent. So, we advocate for that so that we can make people feel they're a part of something. And I think the other thing that we focused on is going to the next slide, as far as our populations, we have to educate our population. And in order to educate, we empower them. And it's not, regardless if you're homeless, HIV, STD, whatever, you're still a human being, and you deserve that warm human touch. And you have to be validated as a person. And it doesn't matter your lifestyle. It doesn't matter. We don't care about that. We're not here to judge. We're here to take care of you and prevent. And that's what we have to give to the people. And regardless of the age, whether you're 2 or you're 82, the respect should be mutual. And that's one thing that we try to incorporate when we take care of our patients. And speaking as a nurse, both of us are nurses, and that's what we do. You just make people feel they are a part of something special. They're not just somebody that we stick and then you leave out of the door. So again, to educate is to empower, and that's the main thing.
Hi, my name is Elizabeth Endress. I'm with the Texas Association of Community Health Centers, and I've actually had other people go co-conspirators earlier. I guess I chased them away, but I did not come up with all this by myself. Our focus was on help paying for care, and one of the first things I, of course, thought of was expanding support for the federally qualified health centers in the region so that we can provide more services to more people, as well as to clarify what type of services and who we provide services for. Another discussion we had was providing health and health insurance education promotion, which are 2 separate things. So not only do you know how to use your health insurance, so understanding deductible insurance, all that, or copay and all that good stuff, also, how do you select a provider? What do you need to do to engage in healthy behaviors? Going back to the prevention. What else? Also providing copay and deductible assistance for those who have health insurance. We've often found that people have gone out there, bought their insurance, they can afford the premium, they can't afford the copay or deductible. So we need to provide them additional assistance in paying for those as well. Many people have mentioned collaborations, but we specifically wanted to highlight the need for entities across from federal, state to local to share information regarding eligibility requirements for programs and how one might affect another. For example, SSI may affect your Medicaid eligibility. So, and people applying for these things don't know that. So the people who are helping them apply for that need to tell them this information. Also expanding in-network service providers. We found with a number of the quality QHPs throughout the state that not all providers in that region are providing services under that health plan. So we need to be sure that these health plans are providing services for all possible providers. And then of course, last but not least, the elephant in the room, Medicaid expansion in the state of Texas.
All right. Okay. Use the microphones. I'm Victoria Brita. I work with WeViva, and Andre and I were representing the nutrition and weight management table. So what we discussed were some of the challenges are working with low-income, elderly populations, persons with disabilities, and that comes with access to healthy foods, food deserts, food swamps, things of that, the cost of healthy foods, not having transportation to get there, not having sidewalks, which kind of leads me into the systemic section that we discussed, which is more of built environments needs and having just safe crosswalks and more parks and lighting and walking, and then more kind of working with, we weren't sure what the word for it was, but like maybe incentives for convenience stores and local shops to have like tax breaks or something so that they can provide more healthy food in their stores and so that it's more accessible to the people living in those neighborhoods. Also just, pressure on grocery stores and more organizational partnerships with the city and state and federal levels.
Point that out. Clifford, you're one of those people working on it.
Yes, and in terms of systemic changes, we talked about both social and structural systemic changes. The term that came up frequently was culture, applying both at a personal level and at an institutional level. So both caregivers relating culturally to their communities being served, and also recognizing traditions that may conflict with the services being offered. I think that respect for the patient, in terms of patient-centered or patient-controlled choices, they may sometimes have choices for non-treatment. I'm not sure how our metrics might deal with that if their choice is hopefully with informed consent to not be treated. It could affect could look like it's skewing outcomes, but it might in fact for the patient be regarded as an improvement in their quality of life.
Clifford, can you mention your table? Because you haven't mentioned your topic.
Yes, our topic is cancer support and end-of-life care. There were a couple of other participants here that had to skip out before now. So hopefully there can be a greater community-wide culture change that would place a greater emphasis on and value on end-of-life experience. I think if that culture were enhanced, valuing the end of life, that would automatically bring into play adequate funding and strategies. And hopefully each culture represented will take some of the best qualities from the others and alter their own traditions accordingly. Now, in terms of technological changes, infrastructure for systemic change, Again, database innovation can play a large role. Technology innovations that would connect people with resources. Right now we're using 211. I heard mentioned earlier that organizations can yet lead people on potentially on wild goose chases from one spot to another. And the potential for artificial intelligence programs such as IBM's Watson to help address some of those gaps in referrals, I think is very high potential there. And I would also think that we may be in a position here in Austin to use our Google Fiber infrastructure to help with any of these issues. Maybe we can even create them to get a moonshot project for Austin that would relate to this. Now to wrap up, I think that one systemic change may have to do with privacy expectations that would help people to be more connected and less isolated.
I'm Caitlin White. I'm a planner with Capital Metro, and our table discussed transportation to care. Many of the challenges that we discussed echo discussions that have already been had. For instance, the challenge of keeping up with demand and lack of capacity to serve the need considering our limited resources. The challenge of lack of coordination between organizations within a region or a municipality, even when addressing similar needs and populations. And we also discussed the challenge of land use policy and cost of housing contributing to the suburbanization of poverty that poses additional challenges to affordably providing transportation to healthcare for our most vulnerable populations. In terms of systemic change, we talked about the need for breaking down silos and normalizing coordination across sectors that may not be traditional partners. So, for example, when housing is developed, especially affordable housing, and when healthcare facilities are sited or developed, it's vital that transportation is at the table before those decisions are made so that we don't continue to perpetuate this problem of having a dispersed population that can't access the care they need because they're located in areas that transit and other transportation services can't easily or affordably serve.
Good morning. My name is Annette Juba. I work for Age of Central Texas. I had a discussion at our table about the needs of the elderly. One of the challenges we feel is even defining what are best outcomes for people who are aging. Oftentimes, situations you're living with as you're aging don't fit in traditional disease preventative models. Are we looking to eradicate disease? What are we really looking for? What is successful aging? In terms of systemic changes, then, one of the most basic is even how we talk about aging. We talk so much about the tsunami of the seniors, and we talk about the sinkhole of dementia. And no wonder that there's not a lot of focus on this because it seems so depressing. It seems so like it's on a irreversible downward trajectory, I guess. So reframing these things, what are the benefits of seniors in the society? How can they be an asset to our community? How can we incorporate them more? We also agree with the need for increased awareness. I feel a little bit like the nurse from the city who talked about immunizations and, we're not your BFF until you need us. I think a lot of us in the aging field find people who come to us, I had no idea that you existed. Well, people don't really want to talk about aging issues until they actually need them. So increasing awareness. We also felt like an important systemic change was supporting family caregivers. Right now, family caregivers are providing enough care that equals all the Medicare and Medicaid spending. We need to support the work that they're doing because our medical system can't financially support that. So increasing focus on family caregivers, support to family caregivers, incorporating them in the work that's going on.
My name is Carolyn Schwartz. I'm with Ronald McDonald House Charities of Central Texas, and no one came to my table, which was residential care and independent living. So I'm going to report out, but I do want you to know that what I'm going to say comes with an aging lens to it, since I merged with the aging table. The challenges are pretty much what you can expect is affordability, supply, so having enough housing, especially for low-income Medicaid-eligible folks. And then for systemic changes, we talked about the possibility of, this one's a big one, but senior-friendly villages and neighborhoods where, you know, if you're not close to your family, but the whole community plays a part in being a part of the housing and taking care of the seniors who are living in that neighborhood. Big one was preventing isolation. If we could make activities and different things available to people in residential care situations where it would take the cost out of it, so make it financially available to them, as well as with the transportation available to them to get to activities that could extend people's lifespans. And I think that's it.
I'm Ken Flippin, and I'm with Enroll America. I'm a regional organizing lead, and our table was focusing on medical care for low-income populations. And one of the major things we talked about was the fragmented nature of the healthcare system, as well as the culture that leads to. And one of the biggest things that we need is more communication and better collaboration among groups. And so I'll take that opportunity to say that's what we do at Enroll America, is that we do a lot of collaborative partnerships, and many of you in here we've partnered with before. If you haven't talked to us but you want to work with us, we basically educate people about the marketplace. We do follow-up as well as outreach events. And so if we can work with you, get in touch with me, or we have a table outside where you can sign up. But the other big thing that we talked about is, especially for low-income communities, there's a lot of different barriers, and some of these have been talked about in other places, but childcare. When a person is has an appointment or has a need, a lot of times they're making a choice between their children and their own health. And transportational goes along those same lines, and so having more options. Another infrastructure solution we talked about was better use and more use of prematuras. In South Texas, that has been a very successful program that we've integrated with to help educate people. And I think a better use and a stronger use of those programs. Also, an easier understanding of all the different systems that we have in a place like Travis County. We're blessed to have a lot of different safety net programs, but you know, there's so many different things, and people have talked about a one-stop shop or multiple access points to the same system. Something like that's very important. And then just in general, a lack of knowledge about what health insurance means, deductibles, co-pays. So information or education systems that educate people in those areas. And so all of those different things are things that we talked about, that the infrastructure really needs to change. Better communication and collaboration will help us get to those solutions.
Claudia Lindenberg, Central Health. Our table was medical care for the low-income population. So the challenges we identified was the complicated system that we have in place currently. The time of day is not particularly conducive to people going in to get care. Also, the limited resources that the clients could have due to either the limited time they have or the funding. Also, there's a lack of coordination of care, the integration of services. So if you go to a primary care and you're referred to a specialist or ancillary, that is extremely hard to figure out who's on first. Also, the lack of access to dental care is really crucial in our community. And the lack of cultural diversity, understanding, literacy, and language. As far as how the systematic changes to address these challenges is that we need to change the focus to a more of a community return on investment, just versus just looking at the medical model. Having a stronger navigation system online, in person, more of a person-centered approach, and then also the clear roles and understandings between the providers, who does what, and then they communicate that. Also, we need to look at supporting more of a model of integrated services in one place, more of the FQ model where you have a true integration of services. Also, a mechanism to support care coordination. So to move the reimbursement to, instead of just being paid on encounters, more to outcomes. And also working on the training the workforce to more of a community-based model versus a model in the hospital or just in the traditional clinics. And then also the earning potentials for the providers to move it towards away from most of the earning potential in the specialty world to more of a earning potential in the primary care world.